Hello, welcome, good morning, good afternoon, good evening, wherever you're tuning in from. This is the last of 2022's Facebook for Neurology's webinar, and we want to have a special shout out that this is the pre-Christmas edition. So a little free present for you today. This is also the World Cup edition. We're going to be having a little chat about that probably at the end of this session. Laurent and I got some things to say about that. So, but without further ado, thank you very much for tuning in. And thanks very much to Hallmark Advanced Veterinary Imaging for sponsoring this session. Today, we have great pleasure in introducing Dr. Carlotta. Now, I'm really sorry, but I'm terrible pronunciation, but Remelli.
Yeah.
Is that okay? Oh, thank you very much. Yeah, so I have great pleasure in introducing you, and thankfully didn't destroy your name. Brief introduction to Carlotta, who is very brave being here today. All our speakers this year have been in the early stage of their career. We want to encourage that moving forward. This is a great opportunity to share your work with people interested in the neurology field. Carlotta graduated from the University of Padua in Italy, and so shout out to all of our friends at that university there. In the final 2 years of study in Padua, she was an intern student at the neurology unit, and hence there's going to be some presentation coming up very shortly of some of the work that was done there. Currently, Carlotta is taking part in a 1-year rotational training program at the Anacura Veterinary Hospital I Portoni Rossi in Bologna. Oh, that was good, eh? And is going to take part in a rotational internship program starting from January 2023 at the same institution. And I believe Laurent and I have a friend there, Dr. Marco Bernardini, and hopefully Marco is listening. Marco, it's been a long time, and we need to get together for a drink. But thanks for your support here, and thanks for supporting Dr. Carlotta Remelli today. So I'm going to hand over to you, Carlotta. Thank you so much for giving up your time. I know it's early evening there in Italy, and you've got your work to present. So thank you so much for turning up. I'm going to hand over to you now, and Laurent will put your presentation on the screen. So good luck and take it away.
Okay, so thank you, Dr. Platt, for introducing me, and thank you all to join this journal club. It is an honor for me to be here and tell you about this paper titled Magnetic Resonance Imaging Highlights the Meningeal Involvement in Steroid-responsive meningitis-arteritis and suggests the inflammation of the surrounding tissues in 70 cases. It was published on Frontiers in Veterinary Neurology and Neurosurgery in August 2022. First of all, a brief review of the state of art of the pathology. SRMA is an immunomediated disorder commonly recognized in dogs. Even if young dogs between 6 and 18 months of age are usually affected, the disease is also reported in older dogs. Any breed can be affected with a prominent predisposition in Beagle, Boxer, and Bernese Mountain Dog, which are the breeds in which the pathology was described first, but are predisposed also Border Collies, Springer Spaniel, Weimaraner, Nova Scotia Duck Collie Retriever, Jack Russell, and Whippet. An acute and a chronic form of the disease may occur. The former is characterized by cervical pain and stiffness, whereas in the latter, neurological deficits are usually present. It is also reported that SRMA-affected dogs may also show myositis and polyarthritis. The intravitam diagnosis is based mainly on patient signalement, history, neurological examination, and cerebrospinal fluid analysis. I will say CSF from now. Whereas the role of the magnetic resonance imaging as MRI in the diagnostic workup of SRMA is poorly described in literature. What is present is mainly reported in 3 papers. The first is the review by Andrea Tippold of 2010, an update on steroid-responsive meningitis-arteritis, where it is reported that MRI may demonstrate contrast enhancement of the meninges. In this paper, by Aminaga and colleagues of 2013 about spinal cord disease of unknown origin, they found steer muscle changes apparently associated with inflammatory cervical spinal cord disease. And the last is an American paper by Lau and colleagues of 2019 about clinical characteristics, breed differences, and quality of life in North American dogs with acute steroid-responsive meningitis-arteritis. And the authors found in the MRI of some dogs meningeal contrast enhancement, T2 hyperintensity or contrast enhancement of the cervical paraspinal muscles, and lesions within the cervical spinal cord with variable contrast enhancement. Therefore, we can say that extensive reports about the usefulness of MRI in the diagnosis of SARMA are lacking. Then the aims of the study were first to investigate the characteristics of MRI studies of the cervical spine of dogs diagnosed to be affected by SARMA, and second, to compare the diagnostic capability of MRI obtained with low-field and high-field MRI units. This was a multicentric retrospective case series with 2 centers involved, the Veterinary Teaching Hospital of the University of Padua and the Anicura Veterinary Hospital I Portoni Rossi in Bologna. For what concerns materials and methods, we searched in the database for SRMA cases between 2008 and 2021. Inclusion criteria were data about signalement, history, and neurological examination available, as well as CSF information concerning cell count, neutrophil percentage, and albumin concentration. About MRI, the MRI studies had to be available for review and had to include at least pre- and post-contrast T1 weight images, either with or without fat suppression, and acquired in both the transverse and sagittal planes. Moreover, T2 weight images or steer images in the transverse plane had to be present. And the post-processing subtraction technique was used on the T1 weight images to highlight contrast agent uptake. A low-field scanner was used between 2008 and 2018, whereas a high-field scanner was used between 2018 and 2021. This table shows the main structures we analyzed in the study in the first column, so meninges, nerve roots, synovium of the articular facets, and muscles. For each structure, a score from 0 to 2 was assigned, with 0 meaning no contrast enhancement, 1 meaning mild contrast enhancement, and 2 meaning marked contrast enhancement. Then, the MRIs were globally classified based on the distribution of the enhancement as absent or involving one or more of the following cervical structures, so meninges, synovium of the articular facets, and muscles. Then MRI features and CSF analysis results were compared and statistical analysis was performed. A 2-proportion Z-test for equality of 2% was applied to compare in low-field and high-field MRI the enhancement of the structures, the incidence of synovial and muscular enhancement, and the increased conspicuity of the meningeal enhancement through the subtraction technique. A Kruskal-Wallis non-parametric test was applied to analyze the CSF cell count distribution in the 3 MRI groups based on the degree of meningeal enhancement and in the 3 MRI groups based on the distribution of the enhancement between cervical structures. And this test was applied on total MRIs, then on low-field MRI alone, and on high-field MRI alone. Moving on, talking about results. 70 cases were included. About the medical records review, there were 50% of male and 50% of female. Breeds most represented were boxer, mixed breed, Bernese Mountain Dogs, followed by other breeds. Median age at first presentation was 10 months, and the duration of clinical signs was less than 4 days in 25 dogs, between 4 and 10 days in 24 dogs, and more than 10 days in 21 dogs. 53 dogs received previous therapies in the 10 days before referral, consisted of glucocorticoids in 9 dogs, non-steroidal anti-inflammatory drugs in 27 dogs, opioids in 24 dogs, and antimicrobials in 24 dogs. Cervical pain or stiffness were present in all dogs, and other clinical signs were paresis in 17% of dogs, ataxia in 20% of dogs, and pyrexia in the 75% of dogs for which temperature was available, so 24 out of 32 dogs. In 57 dogs, information about the follow-up were present, and the response to the immunosuppressive treatment was reported to be good in all of them. About CSF analysis, CSF was collected from the cerebellomedullary cistern in 90% of cases and from the lumbosacral space in the remaining 10%. Median cell count was 945 white blood cells per microliter, and the marked plasticitosis, meaning more than 500 white blood cells per microliter, was found in more than 64% of cases. On differential cell count, more than 60% of neutrophils were found in almost 93% of cases. For what concerns MRI images review, enhancement of one or more structures was found in 98.6% of cases, as you can see in this figure. We have T1 weight pre-contrast images in the upper row and T1 weight post-contrast images in the lower row. In the post-contrast images, we can see from left to right meningeal contrast enhancement here, nerve root enhancement here, synovial enhancement here, and muscular enhancement here. Meningeal enhancement was found in 87.1% of cases, whereas nerve root enhancement was found in 14.3% of cases. Synovial enhancement was found in 48.6% of cases, and muscular enhancement was found in a similar percentage of 48.6%. The post-processing subtraction technique increased the conspicuity of the enhancement at meningeal level in 42 cases, meaning 60%, as you can see in this figure. From left to right, we have pre-contrast T1 weight image in A, post-contrast T1 weight image in B, and the subtracted image in C. In the subtracted image, we can see, pointed by the arrow, a meningeal enhancement, which is not easily detectable in B. A comparison between T1 weight images and T1 weight fat-SAT images was made in 7 cases in which both the sequences were present. And when meningeal enhancement was present, this was better seen on fat-SAT images in all but 1 cases. Moreover, the enhancement was easily detectable on T1 weight images only for subtraction, as we can see in this figure. So we have T1 weight images in the upper row and T1 fat-SAT images in the lower row. From left to right, we have pre-contrast images, post-contrast images, and the subtracted images. In the post-contrast fat-SAT image, we can see, pointed by the long arrow, a meningeal enhancement here, which is visible in the T1 weight images only for subtraction, and pointed by the short arrow here. A comparison between T2 weight images and STEER images was made in 8 cases. Muscular lesions were present in 5 cases, always better visible in STEER. And this figure is not in the paper, but I want to share it with you because we can see a muscular hyperintensity in both the sequences, but better visible in STEER here. On the comparison between low field and high field MRI, no statistical difference was found regarding the conspicuity of the enhancement in the meninges, synovium of the articular facets, and muscles, whereas a mild significant difference was found in the identification of nerve root enhancement. The subtraction technique increased the conspicuity of the enhancement at the level of meninges in almost 70% low field cases and 40% high field cases. Moreover, in 10% low field cases and 15% high field cases, the diagnosis would have been missed without the use of subtraction. Anyway, no significant difference was found between low field and high field MRI in the utility of this technique. About the comparison between MRI findings and CSF analysis results, These graphs show the CSF cell count distribution in the 3 MRI groups based on the degree of meningeal enhancement. So we have group 0 with no enhancement, group 1 with mild enhancement, and group 2 with marked enhancement. Graph A is about all MRI, graph B is about low field MRI, and graph C is about high field MRI. We can see that if we consider all MRIs, a significant difference between CSF cell count is present between all the 3 groups, whereas if we consider only low field MRI, a significant difference in CSF cell count is present between group 1 and group 2, and no significant difference between groups are present if we consider only high field MRI. This graph shows that the CSF cell count distribution in the 3 MRI groups based on the distribution of the enhancement between cervical structures. So group 1 are cases with meningeal, synovial, and muscular enhancement. Group 2 are cases with meningeal enhancement alone, and group 3 are cases with synovial and or muscular enhancement but no meningeal enhancement. Again, the analysis was made on all MRIs in A, on low field MRI in B, and on high field MRI in C. And we can see that considering all MRIs, a significant difference in CSF cell count is present between group 1 and group 3, whereas no significant difference are present if we consider only low field MRI or only high field MRI. Now, I want to discuss with you the results grouped by the aims of the study. So the first aim was to investigate the characteristics of MRI studies of the cervical spine of dogs diagnosed to be affected by SRMA. And MRI showed abnormalities in 98.6% of cases, confirming the usefulness of this exam. And MRI features suggestive of meningeal inflammation were found in 87.1% of cases, whereas the incidence of synovial enhancement and muscular enhancement was the same for both conditions and was 48.6%. Cases of SRMA and polyarthritis, as well as cases of SRMA and meningitis, have been reported in the literature. And about SRMA and polyarthritis, in this paper by Webb and colleagues, they found steroid-responsive meningitis-arteritis in dogs with non-infectious, non-erosive, idiopathic, monomediated polyarthritis, and this condition was found in the 46% of cases with polyarthritis and cervical hyperesthesia. So we think that the high incidence of synovial enhancement detected on MRI in our study reinforced the hypothesis of that study that polyarthritis could be more frequent than clinically expected. About SRMA and myositis, in this paper we quoted before, Minaga and colleagues found steer muscle hyperintensity in the cervical muscles associated with inflammatory spinal cord disease of unknown origin, and they suppose the extension of the meningeal inflammation to the paraspinal muscle through spinal nerve roots, as could happen in some of our cases. But since the majority of our cases with muscular enhancement didn't have a concomitant radicular enhancement, we suppose the spread of inflammation also through arteries, which in addition could explain the presence of the enhancement in the synovium of the articular facets. About the subtraction technique, the utility of this technique at spinal levels is reported, especially for areas of contrast enhancement that are close to fat, whose bright signals tend to hide pathologic lesions, quoting Dennis and May. And our findings fully support its application, so we would recommend the use of subtraction on MRI of suspected SRMA cases as the meninges are contiguous to the epidural fat. About steer images, in the previous report on inflammatory spinal cord disease, muscular hyperintensity was seen in most of the cases and was detected better in steer than in T2 weight images. We have seen a similar feature in our population, supporting the inclusion of steer sequences in the MRI protocol of cases with suspected SRMA. The second aim of the study was to compare the diagnostic capability of MRI obtained with low field and high field MRI units. First, no statistical difference between low-field and high-field MRI was found regarding the conspicuity of the enhancement in the meninges, synovium of the articular facets, and muscles. Then, a low-field MRI can be used during the workup of SRMA cases. The only structure for which a significant difference was found was nerve roots, for which high-field MRI was more efficient than low-field MRI, probably for the higher spatial resolution of a high-field scanner. About the subtraction technique, no significant difference was found between the utility of subtraction in low-field and high-field MRI, so its application is always recommended regardless of the field used. About fat-suppressed images, the acquisition of fat-sat sequences is generally performed only with high-field MRI because the chemical shift between fat and water is too small in low-field MRI to achieve a selective chemical saturation of fat without also producing water saturation. And this, again, highlights the higher efficiency of a high-field MRI. About the cross-match between MRI findings and CSF results, basing on the graphs I showed you before, we found that with a low-field scanner, the more the meninges are inflamed, the more the enhancement is visible, while a high-field scanner permits the identification of the enhancement regardless of the degree of inflammation shown by the CSF analysis. And we think this is probably due to the higher spatial resolution of a high-field MRI. Instead, when pulling all the cases together, stronger was the degree of contrast enhancement in MRI, and significantly higher was the CSF cell count in the CSF analysis. And we think that a possible explanation for this trend is the increased vascular permeability due to the arteritis in this inflammatory condition, which could explain both the contrast agent leakage and the cellular migration from the vascular compartment. In 9 cases, meaning 13% of cases, there was no meningeal enhancement in spite of an abnormal CSF. This is not so unexpected if we consider that lack of contrast enhancement in inflammatory condition is well described in the literature for what concern the other meningoencephalitis of unknown origin, as reported in these papers. And moreover, 4 out of 9 dogs in our study received glucocorticoids or non-steroidal anti-inflammatory drugs treatment before referral, which could have altered the MRI findings. Anyway, 8 out of 9 cases with abnormal CSF but no meningeal enhancement had concurrent synovial and or muscular enhancement, and the CSF cell count of these dogs was significantly lower than the CSF cell count of cases with synovial, muscular, and concurrent meningeal enhancement, despite a greater percentage of cases belonging to the latter group received glucocorticoids or non-steroidal anti-inflammatory drug treatment before referral. Then we could speculate that different forms of SRMA or different stages with different tissular targets could exist, and future studies are clearly needed to investigate this hypothesis. Lastly, according to the initial search of the database, 2 dogs had a suspected diagnosis of SRMA in spite of normal CSF analysis and were therefore excluded from the study. The first case was a Bernese Mountain dog of 22 months of age with a previous diagnosis of SRMA 15 months earlier, and this time cervical pain was found on neurological examination and meningeal enhancement was found on MRI. As chronic relapsing cases may have normal CSF, we suppose this dog could be affected by a second episode of SRMA. The second case was a boxer of 4 months of age with no history of cervical pain, and the enhancement of the synovium of 2 pairs of articular facets was found on MRI. Then this dog could be affected by primary polyarteritis with cervical involvement. But since a concurrent synovial enhancement was found in almost half of our SRMA cases, and since it's reported that SRMA cases may sometimes have a normal CSF, we suppose that this dog could also be affected by a form of SRMA plus polyarteritis in a non-typical form, in a stage in which the aberrant immunomediated response currently does not involve neurological structures, but future studies are needed also on this topic. This study has several limitations, mainly due to the retrospective nature. First of all, there was no common gold standard diagnostic test, probably for the long duration of the study, encompassing a 13-year period. Then, even if the diagnosis was made on a combination of clinical and diagnostic information, the risk that a few cases with other disease mimicking SRMA were included does exist. Then, MRI protocols varied for the years, and another limitation is the lack of control group and the fact that the observers were not blinded about neurological examination. Then, a limitation is the lack of histopathological confirmation for both neural and extraneural tissues. So, which are the conclusions of the study? Answering the first aim, the most frequent MRI finding in SRMA cases is meningeal enhancement, often accompanied by synovial and or muscular enhancement. And when meningeal enhancement is absent, less marked CSF abnormalities are usually present. Answering the second aim, both a low field and high field MRI have a good diagnostic overall capability. Although high field MRI enables a more thorough investigation thanks to specific sequences such as FAT-SAT sequences. So concluding, this study highlights the usefulness of MRI as a complementary tool to CSF analysis in the diagnostic workup of SRMA and suggests a possible diagnostic role of MRI in cases with a normal CSF, but a clinical presentation suggestive of this condition. And clearly, further prospective studies are needed to complete the description of MRI patterns in SRMA cases and to more reliably compare low field and high field MRI. So that's all, and thank you for your attention, and I will be happy to try to answer the question you may have.
Thank you so much, Carlotta. And I have to say, I'm really impressed, by not only the quality of the study, but also, how professional you've been in doing this presentation. I need to remind everyone that Carlotta qualified. Would you qualify last year, isn't it, from vet school, or a year ago?
Yeah, 1 year and a half.
And so, from someone at the level of career, all commendation, and I think you got a very bright future, in front of you. We have a question from another very smart, neurologist, Kuhn. And Kuhn is asking, you can read the question, Carlotta, while I discuss it. There have been, as you mentioned in your presentation, cases of meningitis with concurrent polyarthritis. In the cases where you saw synovial enhancement, did you correlate whether or not there was also evidence of polyarthritis in this case? So did you do joint tap and see if it correlates with the synovial enhancement?
Sorry, I need to read the question.
Yeah, I leave you to read.
Yeah. Okay.
So did your dog at joint tap, when you diagnosed meningitis, and did the joint tap show an inflammation, and at the same time you could see
okay, I got it. Sorry.
on MRI of the synovial joint?
Yes. So the answer is no. No, it was a retrospective study, so we didn't have data about the synovial of the other joints, and also about the appendicular joints. So we didn't have this data, but we think that it would be interesting to analyze it in a prospective study maybe, and to try to of other joints to confirm or disprove this concurrent presence of SRMA and polyarthritis, I think.
Okay. There is another question from Befan. I'll leave you to read, but Befan is asking whether or not you collected both cisternal and lumbar CSF, especially when you report some of them at normal cell count. Very old study show that there is more diagnostic yield if you collect with lumbar puncture in this case, but I don't know if you collected from both as well.
No, we. I think probably for the retrospective nature of the study, we have just the data about on the database. So where is reported maybe that CSF was collected from the lumbar space. I don't know if they tried on the cerebellum dorsal and they didn't take it, or yeah. I can answer the question for this.
Yeah, obviously people need to know it was a retrospective study, so that presents some difficulty. And
sorry, yeah, I think it was collected from one site.
From one.
Yeah.
Good. There is a fairly similar question. The second part is exactly what we discussed, deciding. I think someone will agree that in the case of meningitis or suspected meningitis, I think for the people listening to us, is like with if you suspect polyarthritis, the more joint you collect, the more diagnostic yield. And I think with meningitis, it's always best practice to try to collect from cisternal and lumbar to increase, obviously, the chance of diagnosis. But the first question was, what kind of secondary treatment will you use in cases that don't respond well to steroid? I mean, what in the case that you've reviewed, what was the second line treatment when steroid were not, doing the job?
Okay. So I'm afraid, but I don't have the answer because this work was about the diagnosis. So we found that for all the cases in which there was information about the follow-up, the response to the treatment was reported to be good. But in all of the cases, I think it was with glucocorticoids, and I don't remember now if some case had an art therapy. But I think that you have more experience than me in this thing. So
we can help you with that. I think someone can also say, I think from what I've seen over the years, compared to cases of MUO meningitis, when you rule out, when they fit all the box, they are young adult dog or immature dog, and you got CSF with neutrophilic pleocytosis, and you rule out all the infectious, cause. We say the large majority respond very well to immunosuppressive dose of steroids. The case that don't tend to do well tend to be the case where steroids have been used maybe, or they have been reduced too quickly, and they could be, more difficult to control long term. I think there have been only very few cases where I needed to add something else. And something else is like for a lot of immune-mediated, condition, there is no ideal treatment, and it could be anything from azathioprine, cytarabine, cyclosporine, leflunomide, and so on. But I don't know, Simon, if you have the same experience with that. You're muted.
There we go. Okay. I'd agree. I think that this is a condition that you hit it really early, aggressively with steroids, and it doesn't seem to need an additional medication most of the time. Laurent and I are of a generation where we love steroids, although we agree that there are some problems with them, and people better than us and in the newer generations look to steroid spare, and so. Although it might not be necessary to add a second drug, there's a feeling that adding a second drug means that you could use less steroids, and so potentially have less of the harmful side effects that would be associated with their use. But it may not be on a purely disease treatment basis. It may not be necessary.
And there is another question, Carlotta, we may answer for you. How long do you keep them on steroid? And then Thomas also asked, when do you try to reduce? I think, Thomas, with immune-mediated disease, you need to consider that you need to tailor the treatment to the dog. And it would be wrong to try to fit a given treatment plan to every single dog. And personally, I usually start 1 mg per kg BID for at least 2 weeks. And what I would expect, if everything goes well, is that within 2 weeks, there is return of, the signs are resolved. And if I achieve that, then I'm going to reduce every 2 weeks, and I keep them on treatment for a minimum of 3 months. You could potentially run CRP, after 3 months to see if it's elevated, or repeat the CSF to guide you, or purely go on clinical sign. If after 2 weeks there was no good improvement, that's where I will consider adding something else, because I will be worried to keep the dog on a high dose steroid for too long as well. But it's really to adapt the treatment to the dog. There is no something that fit every single dog the same. Simon, again, if you want to add.
Yeah, it is an individual, but a little bit like the whole MUE, MUO phenomena that we're treating based on clinical signs. And as Laurent said, there are some biochemical monitoring parameters, CSF in serum that we could use, and many owners, if the dog's doing well, probably don't really want to go through another CSF tap, but that is documented as a way to at least establish whether there's ongoing inflammation. And then the CRP, the C-reactive protein, is probably now a more commonly pursued manner for us to see if there's an ongoing inflammation as well. But even with all those being normal, if we reduce the medication to hopefully stop it, sometimes there are relapses.
And there was a comment from Alex mentioning an article about SRMA with cytarabine. Yeah, I agree with you, Alex. But the thing you need to maybe take into consideration is that if there is a treatment that is easy to give at home, and we know that for, let's say, more than 90% of the dogs, they will respond to that. The flip side of using cytarabine is that it's a cytotoxic drug. You need to take a lot of precaution when giving it. There is a cost implication. I mean, in the UK, to give cytarabine with all the cytotoxic regulation have a high cost. I mean, the owner coming back as well to have the cytarabine given, that's something to weigh. And personally, as someone say, with the generation where, if something works and, it's cheap and you do the trick, then we tend to go for that. It doesn't mean you should not use cytarabine, but you need to put in the balance the cost and all what it implies as well using cytarabine. I think we've done a question. Carlotta, I just want to reiterate that, fantastic job. You should be very proud of yourself to put yourself forward, to come on this forum. I think is amazing. And as I say, I've got no doubt the future will be very bright, for you. I don't think the future of the England team at the World Cup will be so bright.
Here we go. Go.
I think we need to talk about it very briefly. As you know, France is playing against England on Saturday. At least they can leave the World Cup with a head held very high, having gone up to the quarterfinal and losing against the best team in the world. So, don't. Yeah, still think it's a good achievement. It's still good enough. Don't be too hard.
Laurent is apologizing. Laurent is apologizing to our Brazilian viewers right now who might have an argument. Maybe the Dutch, maybe they'll have an argument as well. But we on our next webinar, to be held at the beginning of February, when England quite possibly are world champions, we will review this topic again. But thank you again, Carlotta. Really appreciate it. As Laurent said, a fantastic presentation. Really great, especially considering your stage in the career. It really is great. Thanks to everyone who tuned in today, and thanks again to Hallmark Advanced Veterinary Imaging for sponsoring this session, and thanks to the nightclub, wherever it is that is hosting Laurent's current video camera with the evening lighting there. Join us again at the start of next year, or first week of February, hopefully, for the 2023 Facebook webinar series. And any one of you out there who have a publication in the works or know it's getting accepted soon, a study that you'd like to present, please Carlotta has set the bar very high, but please put your name forward, get in touch with us, and we would love to give you a platform here to talk about your study. Thank you very much.
Have a wonderful Christmas, everyone, and thanks, Carlotta, again. Bye-bye.
Thank you for this opportunity.
Yep. Thank you.